Acute World, Marlin Blakeney here. Just want to check up with you guys. I have another podcast right here for you. A great friend of mine, and obviously Rock Chalk Jayhawk. And I want to tell you this right now, up front. I don't set this up to be like just all Jayhawks or all this and that. It just happens that there's so many Jayhawks out there that they're all doing great things and they end up working with us. So we're looking forward to this one. This one will be great because as addition to, if you guys have not seen the original Q World podcast where we did the interventional cardiologist with the electrophysiologist, and it was a great informational. We got great feedback from it. I think the medical schools really loved it. And we really want to dive in deeper though. This is a dive in deeper than that was. That was more of a broad feel to give information out. But now with COVID, now with interventional cardiology getting worse, we want to get more in detail with what specifically is interventional cardiology. So without further ado, I got Prasad here, MD at Mercy in Springfield, Missouri. He's here to help us out and talk a little bit about his history, about what's going on. And if you have not done this yet, please do subscribe to our channel, hit the bell, and say, hey, I want every update you guys have because we've given it and we're giving you guys the real deal. So I hope you guys are enjoying what we're bringing to you. And now we're going to talk really detailed about interventional cardiology. So Prasad, man. It's great. Thanks for taking the time.
Marlon, always a pleasure.
Yeah, well, you know, obviously these guys are busy. They're on call. They're doing cases every day. Medical reps know this as well. These guys do a lot, and their demand now, even with COVID, is very high. So I really appreciate Prasad taking the time to hang out with us and give him a little bit of feedback of what his idea of what interventional cardiology is, what his idea of what medical school should be to residency, and then obviously where you should be when you get into your first practice, and then the future of work interventional cardiology is going to be. So these are things we're going to talk about. Stay tuned. Let's get it.
Marlon, thanks for having me here, buddy.
Yeah, no, it's good to have you, man. I mean, obviously, we're really welcome. It's a privilege that, you know, I mean, literally, you guys do so much. And for you to be here with us, I really appreciate
Well,
that.
thank you for your kind words. It's always nice to chat with a fellow Jayhawker.
Yeah.
So it's always a pleasure. So what's going on, Marlon? What do you need to know about us? Let's have the conversation going.
Yeah, let's do it. So what I want to know is, let's talk about this. First of all, who are you? Where are you from, man? The guy, they want to know. Q World wants to know, who is this guy? Like, he's a real deal.
Oh, well, my name is Prasad. I'm what you call an interventional cardiologist, a fancy word for saying a plumber of the heart. You know, as you guys know, the heart has different components to it. One is the pump by itself, and then the fuel supply to the heart, which are the arteries supplying the heart muscle, and that's what I deal with. You know, fixing blockages in the heart arteries in patients who have stable chest pain, or sometimes people come in with acute heart attacks. That could be 3 in the evening, 3 in the morning, could be any time. So we go in, especially when you're having an acute heart attack or an acute myocardial infarction. Typically muscle dies within a matter of minutes, so you got to be quick. You got to open up that blockage and restore the blood flow to the heart and prevent damage from happening, and that's what I do for a living. And I've been doing this for a couple of years now after graduating from KU, and I wouldn't trade it for anything else. I love this job.
Yeah. So tell them, like, from the beginning, like, where are you from? How did you even believe that this was the idea?
I was born and raised in southern India, out of a conservative South Indian family. My father was a doctor too, and my brother's an engineer. So I've had my inspiration from my dad as to what he did. He was a plastic surgeon by profession. So I've had my inspiration growing up, and I knew I wanted to be a doctor. I was born and raised in southern India. Then I did my medical school there too. And then I really wanted a challenge after that. And since I moved to the U.S. to do my residency and my fellowship and my advanced training in procedures, and then I joined my practice here in Springfield, and here I am. Right. That's how I got to know Marlon. We've worked together in the past, and And of course, I trained at KU, so we've had that bond between us for a while now.
What was it like? So you got your degree, your basic degree. Where was that at? Where'd you get your basic?
Well, in India, we have a different system. It is a British system. So right after high school, you pretty much join medical school. So there's nothing like college, which you have in between, like in the US, where you have a couple of years of college before you decide what you want to go into. In India, you have to decide in high school as to whether you want to be, whichever profession you want to go into. It's got to be decided early. So I made up my mind pretty early on, but I just wasn't sure as to which specialty I was going to go into as far as my profession was concerned. I vividly remember when I was trying to make up my mind that I did watch a cardiac surgery and assisted with a surgeon, and that's when I got to hold a beating heart while he was operating on it. And that was one of the best things I ever did in my life, and that just stands out as a wonderful memory. And at that point, I just decided there's nothing cooler than this, and I wanted to do something with the heart, either a cardiac surgeon or a cardiologist, and that's where I got my inspiration from. I mean, if you think about the heart, it starts when you're born. And when it stops beating, life ends. It works hard, and it's just a fascinating structure. So I think that's where I decided that this is what I want to be a part of. And you hear people having dramatic events like heart attacks, and to be part of that process and helping them heal up, I think that sounded fascinating to me, and that's why I chose cardiology.
All right, well, I think what most people want to know, because we're going to be broadcasting this in India or across the world, from India to U.S., how did that happen, the transition, and how did you pick your med school in the U.S.?
Absolutely. By the time I was in my last year of medical school, we have an internship period, and that's when you kind of work as a house staff and as a practicing physician under supervision, of course. And at that point in time, I had two options. One is to do surgery and stay back in India, which I wanted to do over a long period of time, given the inspiration I drew from my father. But at the same time, my brother was here in the U.S. and he was working as an oil and gas engineer. Oh, wow. And I was getting too comfortable at home. Yeah. So I needed a new challenge. So I decided to move a few continents away and start something new. And I started off doing research in infectious disease and perhaps got into internal medicine. And that's when I really reinforced my intention to do pursue cardiology, and that's how it came about to happen.
Yeah, that's awesome. So what school did you pick when you came into the United States?
Yeah, I did my research in Detroit at downtown Gunshot County Hospital, and
that's a real deal. That's raw. That's hardcore.
It was hardcore.
Yeah.
I mean, it was an interesting place, but you see all of the stuff in the book in that kind of hospital. That's where you want to train when you are a trainee. Even though it's rough, the hours are pretty hectic, and at some point in time, you feel like, why am I working so hard? And subconsciously, you'll be learning so many things, not just all the pathology which you see in the textbooks do you see in a county hospital, but at the same time, your people skills improve. You have different hospitals, you have private hospitals, where there's privileged people coming in, and there's also downtown county hospitals where there's people who have nothing left over, and they still come in. And there's also the VA. You have your fair share of interaction with veterans and all the World War stories and things like that. You develop as a doctor. You see a lot of things. You experience a lot of things. You learn a lot of things in the process. But at also the same time, you grow as a person, because you deal with different stratas of the society, and you help yourself adapt to different people, because medicine has no frontiers, right? And when you're in practice, you can come across multimillionaires in your practice. You can also have multiple different people in your practice, and you got to cater to every different person's needs. And I think that's where it gives you a lot of exposure, that kind of training program. And I loved it. I worked hard. Training was difficult. It was busy, but it was worth every penny of it. That's right. Where I trained. It is a rough place, but it'll teach you a lot of things. I mean, typical work weeks can be anywhere between 60, 70 hours, sometimes even 90 hours. I mean, there's obviously duty hour restrictions and things like that. And then as a resident, you're expected to stay in-house and take call, which means there'll be a lot of nighttime working hours, and there's a lot of physical stress involved. But But over a period of time, you look back and you introspect and you see yourself having grown from someone who had no knowledge in medicine. Of course, textbook knowledge is there, but practical knowledge that comes. Some of the best things I've learned have been at in the middle of the night, and then your senior residents, they sit down and then teach you in the middle of the night, and you become that guy as time goes by. Second year, you sit down and you talk to your residents in the middle of the night and you teach them things, and you see a lot of different varieties. You go to the emergency room, you'll have a wide range of things to see, people coming in with, heart-related conditions, heart failures, and then you have drug overdoses, and then you have lung problems and kidney issues and a bunch of other things, and you learn a lot in that process. And in the morning, your schedules are, set in such a way that you have conferences every day, so that, you have your didactic experience, and also at the same time you have your practical experience where you see patients, you touch patients, and then you change your management every day. You see them getting better. Sometimes you see them getting worse, and you yourself change your strategy based off of that. That is something which I really, really loved.
Right. So that, and that's one thing I think a lot of people outside of med school and medical industry don't understand. Like when you guys go to med school, you're seeing a variety of a lot of stuff. You're not just seeing, you haven't specifically isolated what you're going to do. You're just seeing everything, and you're absorbing so much. And I mean, as far as the content goes, what do you say to these young adults out there right now? It's a lot. Like to learn everything abroad, trying to just absorb everything. I mean, what do you say to them as far as how should they adjust it? How did you adapt to it?
Right. Everybody who steps into residency has a fair idea as to what they want to do, because of all they read in medical school and also their rotations. They have some sort of a couple of interests. Very few actually come out saying, I know what I want to do, or I know I want to do cardiology, or I want to do general surgery, or I want to do vascular surgery. Very few come out knowing what they want to do. A lot of us come out broad. I think the first 6 months is kind of crucial, and you got to keep an open mind and try to rotate through as many rotations as possible in different divisions and see patients, because there's different kinds of practices. Certain practices like rheumatology or studying joints could be outpatients. If you like your 8 to 5, more or less outpatient job, then there's multiple specialties which focus on that, like endocrinology or rheumatology and things like that. Whereas if you like the excitement in the middle of the night and you feel like people having cardiac arrest, you want to be part of this, you want to be hands-on and be in their emergencies, or ER is really good for residency, and anesthesiology, for example. Things change in a matter of seconds there in critical care and anesthesiology and things like that. So I think it's important that we go in with a broad framework, rotate in as many rotations as possible, and perhaps once you're in that 6 months mark, you get a fair idea as to what you like. And if you feel like this is what I want to do for the rest of my life, and I think that's the time when you seriously pursue it, because it involves a certain amount of hard work in terms of seeing a lot of patients, getting letters of recommendation from your attending physicians, and doing research in those, and perhaps getting your names on papers and things like that, and then you gradually work your way out of which one you want to do, and we go from there.
What made you jump from all that experience you just talked about to interventional cardiology, and then what made you choose KU Med, like out of all of them?
Well, a couple of things. Within cardiology, I saw a lot of fascinating things. As I said, there's cardiac surgery, and then there's interventional cardiology where you fix blockages. And there's also cardiac imaging, where there's multiple different ways of imaging the heart, with nuclear imaging or echocardiography, different forms of echo, multiple other things. What I really loved about interventional cardiology was instant gratification. You open up an artery, someone feels immediately better. Sometimes you have a tamponade or fluid around your heart. You stick a needle in there, and immediately patients feel better. Chest pain goes away. You see the artery which is blocked off and just opens up. And that instant gratification was something which was striking, and I really loved it. And I could see how essential this was. This is not a specialty which runs from 7 a.m. to 5 p.m. This is 24/7. And you have people doing this at any given point of time, at any given time, or any time of the day, And the one thing I really loved was when you race against time, and then you got to be thinking at the same time too, and at the same time you got to do what's safest for the patient, and all of this has to be done very rapidly, and that involves a lot of skill, a lot of training, and a lot of mental tenacity, especially if you have to do this over and over again for decades together in the middle of the night, and it's physically, mentally challenging, and to keep yourself intellectually sound and skill-wise be very sound over a period of time. That's the thing which really, really caught my attention. And I wanted to be that guy and wanted to be in that forefront of that action. And the other thing which really fascinated me was emergencies. Besides, the field has evolved in such a rapid manner. I mean, interventional cardiologists often do, fixing blockages in the leg arteries and the neck arteries, and then more recently there's a new branch of interventional cardiology called structural heart disease. I wouldn't call that new. It's been around for almost a decade now. It's completely revolutionized the way we deal with replacing valves. I mean, who would have imagined like 2 decades back that you would go through the groin and fix a valve and be out of there in like 30 minutes? Traditionally, these have been reserved for people who underwent open heart surgery, crack open the chest, and perhaps be in the hospital for a week or so in the ICU, versus no tube down your throat, versus no cracking open your chest, and perhaps you come inside, you get a valve, you go home the next day, and you walk home and you sleep in your own bed, and then you repair valves, by going in through the groin, and the sheer diversity of things and the sheer scope of things was what really fascinated me in interventional cardiology. And every day I go to work and I feel that fascination, and that's what drives me.
Right. So you went to KU, obviously you killed it, you did a great job. I mean, I know medical reps there that have talked about you, they really praise you. So obviously the man, the myth, the legend.
I don't know about that.
No, literally, not seriously. And then you come to Springfield, Missouri. So let's talk about the track that you chose to. So these guys are all right now. They're residents, they're about to be done or they're done, and they're picking out where they're going to go. What do you, now that you've done it and been through it, obviously some probably different ideas of what you think, but what would you tell them that, what recommendations do you have for them to pick where they go?
And I think picking a practice is a very complex decision. I mean, one of my old bosses used to say that you have to think about 3 things. What you do in your practice. What is the scope of practice? Are you going to practice everything, every single skill which you've learned in your fellowship? That's one thing. And which place do you want to live in? And number 3 is how much money you want to make. You could get 2 out of these three things. If it's 3 out of 3, then you take that job. It's a unicorn job. There's not many out there which have all 3. Right. But pick and choose 2 of these. Either you join a practice where you're going to be allowed to do all what you've learned in your fellowship, because there's obviously going to be different partners doing different things, and there's not volumes for everybody to do everything. And if everybody does everything, I'm not sure we'll all be good at what we're doing, because there's got to be a focused effort on certain things. So if you choose a practice, which lets you do all of these things effectively, then you may not be able to live in the place where you want to live, or you may not be able to make as much money as you want to do. Of course, money is not everything, but it's important in life, especially with medical training being so long and perhaps involving a lot of money and things like that. But you may not get the other 2. Whereas if you want to live in downtown Manhattan, New York, you might have 10 other people within a 10-mile radius doing the exact same thing as you've trained to do. So you might not be able to do all of these things which you trained for, but certainly you live in the place of your choice, you enjoy life, and you make decent money and be happy with it. Or you choose a place where you don't want to live, but at the same time it pays pretty good, and you have ample amount of opportunity to help a lot of people with your skill. Then you take 2 out of these 3 things, you'll never get 3 out of 3. But if you do, then take it. Don't even think about it. That's a unicorn job.
So basically what he said is, when you come out of medical school and residency, you're in a lot of debt. So
You're broke.
you're broke. So make the best decision that can help you get out of debt,
Right.
but also give you the opportunity to do what you want to do and what you love.
You know, to look at it in a more objective way, as I said earlier, you cannot sustain this lifestyle for the next 3 decades of your practice unless you love what you do. You got to wake up every single morning, and on your way to the hospital, you got to be like, I'm going to go do something different today, or I'm going to do the same thing again, but I have the same level of excitement. And I think that's probably my top priority if you're going to look for a practice. Look for a practice where you feel like you go in, you make a difference every day, and you love to do the same thing over and over again, or do different things and still have the same kind of excitement. Money will come, money will go, but this is what is going to drive you for the next 3 decades.
Yeah, I agree. That's a great point. Great point. So now we're going to get into interventional cardiology. I think everybody wants to know about this. So things have changed obviously over the decades. If you want to go through the history or what stents, I mean, how detailed you want to get, we can go to what stents, the processes of that, and what you use now, or even just talk about the structure. Let's talk about what's structurally what you do and why it's important to a cardiology department. Let's talk about that.
Absolutely. Stents are one portion of what we do.
Right.
We repair valves, we replace valves, we plug holes in the heart. Stents are one portion of it, but a very important portion of it, because most of our emergencies are, like heart attacks, are treated with stents. And this is pretty much a metal scaffold, which is somewhere between 60 microns to like 90 microns in thickness. Some of the second generation stents, they're often like medication coated. They're basically made of metal alloys, nickel chromium or chromium platinum. It's got a drug coating in it so that once you place these metal scaffolds inside the artery, they stay in there forever, number one. It's coated with medicine so that the body doesn't react too much and perhaps form a new blockage inside of the stents, and that's important. They come in different sizes, different lengths, anywhere between 12 millimeters or 8 millimeters to 38 or 40 millimeters these days, and things like that. So they come in different iterations, and how we place stents. Initially for a long period of time, we were going through the groin arteries and putting stents in the heart, and then we realized that bleeding rates are high, and there's a constant emphasis on reducing mortality and things like that. And we ourselves reinvented our approach, and we started going through the arm to put in stents. And these days, patients just come to the hospital. There's no incision. Go through the arm, quick in and out. Half of them don't realize that we're in there, and that's one of the evolutions. When you rewind 30, 40 years back, heart attacks were treated with, perhaps aspirin, stay in the hospital, some rest, and go home. And then we entered the era of clot busters and things like that, which took up a significant amount of time back in the day, and over a period of time there was a lot of bleeding issues involved with that. So we decided to manually go in and open up the arteries, and that's how balloon angioplasty was invented, where you go in and put a balloon across the occluded artery and you open it up and restore the blood flow. And then we realized that once we just do the balloon angioplasty, that blockages tend to come back. And that's when we went into the era of stents and metal scaffolds to keep that artery open once we opened it up, because once the stents are opened up, they tend to keep the artery with the metal scaffold open. And we entered the era of bare metal stents, where there was no medication coat around the stents, and blockages tended to come back inside of these stents, and that's when we decided that we need to add some medication coatings on the stents to make sure that these blockages don't come back. And then we decided that the stents are too thick and they're shutting down, and so we decided to make them as thin as possible. Then came a 100 micron stent, and then a 90 micron stent, and now we're down to like in the 60s, and we're making it thinner and thinner, and lots of new techniques have evolved. Nowadays you can put an ultrasound inside of the artery and precisely look at the diameter of the arteries to size your stents appropriately, or you could use infrared rays to go inside of the artery all through the arm, a 2 millimeter catheter, where you can you take all these equipment, go inside and do precision stenting. Stents are not only for the heart, they can be for the neck arteries, they can be for the leg arteries. and a bunch of other things.
Right. So we're going to talk to the med schools because they're like listening to you right now. They're like, okay, he's talking about the arteries, but some of them may not know what artery are you going through the arm. What artery are you trying to do right now going through the arm that's making such an impact on your procedures and technology right now? What is that?
Well, I always tell this to my patients. They ask me, it's like, are you going to go through the groin or through the arm? It's like, my answer is all roads lead to Rome, right? Whichever way you go to. Some people have vascular disease. Previously we used to, when the first heart catheterizations were performed, they were performed through the brachial artery, and they used to do cut downs and then go from here all the way to the heart. And then we realized that this was leading to a lot of complications, so we decided to go through the groin artery, which is the femoral artery, and that was much bigger and it's a much straighter shot to the heart. And for decades we did it through the femoral artery. Then we realized, our catheters are too big and we're making too big of a hole to fix things, so we're creating another problem, because during the heart attack and advancing equipment in the heart, you need blood thinners, and this leads to bleeding and things like that. So then we generated data, and that's the beauty of cardiology. Like, there's always data being generated, there's always research studies being performed. There is a constant emphasis on making things better. What we are today is a result of us thinking back, looking at our progress and say, we're not good enough, we got to be better. 1% complications is not good enough, we got to be 0.5, 0.3, we are constantly pushing it. So that's when we switched to the radial artery, and these days, any heart attacks, we come in and we go through the radial artery, 2 millimeters of a catheter, we go in there, and everything we do is microcatheter based, and here we are. So that's some of the history behind interventional cardiology.
So I think what we need to talk about is even more detailed than that. Like, so when patients are coming in and you choose a stent, how do you choose a stent, and then what drug? I mean, there's different drugs on different companies. There's a lot of different companies out there that do different drugs, different beliefs, different results. But how do you choose it? And then talk about the different drugs on the stent and why you choose that stent you use, or per se.
It's a good question. Anytime we put on a stent, we always think about a few things, which is, what is the size of the artery? Because you don't want to put a smaller size stent and not expand it to the full potential of the artery. Solely because the larger you can make the diameter of the stents, lesser the chances of blockages coming back. The more appropriately you can size a stent in regards to the size of the artery, lesser is the chance of stent thrombosis, or the chances of an abrupt clot forming inside of a stent. We call that stent thrombosis. Now, the other aspect is, not only can a stent shut down acutely, which is about 0.2 to 0.3% these days with the newer generation drug-eluting stents, there's another problem as time goes by, especially with diabetics and people with end-stage renal disease. Blockages tend to form inside of the stent. We call that instant restenosis. So when you choose a stent, you want to choose between drug-eluting stents and size them appropriately, appropriate length, and all these factors going. Now the question is, which one do I choose between these stents, right? Right. For that, you need to think about what is the risk factor profile of the patient to develop new blockages inside of these stents. Are they having kidney disease, or they having bad uncontrolled diabetes, or they having bad cholesterol plaque inside of these stents? Then their chances of developing instant restenosis becomes higher. So you want to keep these in mind, and longer the stents or smaller the stents, blockages tend to come back. So the emphasis is on the interventional cardiologist is to make the stent as big as possible. And for that, you have techniques like intravascular ultrasound, or optical coherence tomography, or OCT as we call it. You take an ultrasound catheter inside of the coronary artery, make a run, see how big the artery is, and you determine the composition of the plaque or the blockage you're dealing with, which is either is it cholesterol, is it fibrofatty, or is it just thrombus, or just full of clot, or is it full of calcium and things like that. Then you make a decision as to how you're going to modify the plaque. Something soft can be dealt with by conventional balloons, balloon angioplasty, and then you put in a stent. something harder, such as calcium, needs aggressive modification. We have special form of balloons, like cutting balloons, which have got blades around the balloons, and they can crack that calcium and they can make the stent expand. Or even further, if you get more sophisticated, we do procedures called atherectomies, where you take a diamond burr, which could be either 1.25 millimeter or 1.5 or up to 2 millimeters and above, and we spin it at 160,000 RPMs, or and then we chisel out some of that plaque and nanoparticles which wash down the bloodstream, and then you modify the plaque, and then you place a drug-eluting stent. And a drug-eluting stent comes in different varieties and in different lengths, as I mentioned before. Some of the most common chemicals are everolimus or sirolimus or zodorolimus, and multiple iterations of these medications, which are what you call as anti-proliferative medications. They prevent new tissue from forming inside of the stents, and you choose between one of these stents based upon the size of the artery, the typical composition of the plaque, and how you modified it, and how big you can make the stent, and so on and so forth, whether you can use intravascular imaging, and a lot of these factors go into play. And another factor which really goes into play is the bleeding risk profile of the patient, because once you put metal inside the body, the human body looks at it as a foreign object. It tries to shut it down by forming clots. And to prevent that, you need to have at least 2 blood thinners on board. And blood thinners they have their own downsides, which they can cause bleeding. And if you're above 75, or you have kidney problems, or if you've had a previous bleed, or if you have peptic ulcer disease, or if you're a diabetic, or if you're on other blood thinners or anticoagulants for atrial fibrillation, all these add up, and your bleeding risk goes up. So the larger you can make the stent, lesser the chances of blockages coming back. And the better you modify the plaque, and the bigger that you can make the stent, the better. And if you've used intravascular imaging and optimize your stent appropriately, then the chances of if you have a situation where you have to interrupt your antiplatelet therapy, then you get an extra layer of confidence saying that I've optimized my stent, because only stents which are underexpanded or really small are the ones which typically shut down. And before you put in a stent, these are all some of the factors which go into consideration.
Yeah, that's a great point. So I believe now what they want to know is patients are coming in and they're like, I'm on these blood thinners. Some say 90 days, some say 120. Like, how do you diagnose them? Why do they have to be on blood thinners that long? And I know the race for the stent companies are to make it less.
Absolutely.
So so talk a little about that.
That's an interesting point. Conventionally, the old school of thought is that you need to be on 1 year of 2 blood thinners to keep that stent open, because after 90 days the body sort of forms a little protective film and prevents the metal from being exposed to the blood, and usually the inflammation caused by putting in a stent settles down by that time, and the thought is to keep it going for at least a year. Now, when you come in with an acute heart attack, your platelets are angry, and it's vulnerable plaque. So you want your antiplatelet therapy to be for a prolonged duration of time, ideally 1 year. But if you have a high bleeding risk, you can potentially stop it at the end of 6 months, right? Now, a lot depends upon whether you come in with an acute heart attack, or you were stable, you're going to your work, you had some chest pain, you as a responsible person presented to your cardiologist, you got a stress test. That's what we call a stable ischemic heart disease versus an acute heart attack, which we call as an acute coronary syndrome. An acute coronary syndrome is when the plaque has already ruptured and the platelets are angry, so you want to make sure that your stent's well optimized, and you want to take care of all the vulnerable plaques in the other arteries, and perhaps have a longer duration of antiplatelet therapy. Whereas if you're stable, you've prevented the whole situation of plaque rupture from happening, and when you put a stent in there, you could perhaps get away with shorter antiplatelet duration, which is 6 months, or if you have very high bleeding risk, sometimes even 3 months, because patients sometimes have biopsies or other procedures or hernia surgeries and things like that, where we need to perhaps interrupt these antiplatelet medications much earlier. So you could do that. So to answer your question, it depends on the situation in which the stent was placed. Was it an acute coronary syndrome, or was it a stable ischemic heart disease? That's the first biggest question. The second biggest question is, perhaps what is the length of the stent and what is the diameter of the stent? Longer the stent, greater the risk of the stent shutting down, or smaller the stent diameter, greater the chances of the stent shutting down. So you want to make sure you optimize the stent well to expand it to the fully or its full potential. So that's why intravascular imaging is important. As I said, intravascular ultrasound or OCT to precisely size the stent is important. So if you've done that when you place the stent, then you have this extra layer of confidence that technically there's nothing wrong with placing a stent. And the other thing we've noticed is over a period of time, more metal you have, greater is the chances of the body reacting to it and shutting it down. So that's where the race among the stent companies comes in, and everybody wants to make the thinnest possible stent because there's increasing data being generated to say that if you can place a thin strut drug-eluting stent, which is well optimized by intravascular imaging, the chances of stent thrombosis happening or stent instant restenosis happening comes down dramatically, and hence the race amongst all the device companies to generate a stent which has less thrombogenicity, at the same time make sure that it's thin enough, that it's easily deliverable, and you can put it into very calcified lesions and expand it, and they maintain the radial strength. Those are all important considerations.
Okay. So out of your vision and what your idea is now, today, it's just today, because no one knows what's happening in the future or where it's going to go. But what do you believe is most important in the stent or process that you use for what you're doing every day? You're seeing a variety of different patients. What do you believe is the most important part of the stent, or what they need to have, or what drug even it seems to be working more efficiently?
And I think it's got to be a combination of things. There's no one good answer. A good stent should be one which you can deliver easily. Number one, right? If you can't deliver a stent, you can't treat it appropriately. So it's got to be flexible. At the same time, it's got to maintain its radial strength. If it's too thin and if it recoils, that's a problem too, because larger the stent, less of the chances of the blockage is coming back. So deliverability is important. And then maintenance of its longitudinal and its radial strength. Remember, these are 60 to 90 microns. I mean, these are very thin structures, and you're putting it inside 2 millimeter to like 5 millimeter arteries. So you want to make sure that it retains that radial strength. So that's important. And you want it to be thin enough to a point where it maintains its strength and reduces the amount of thrombogenicity. And I think the bigger challenge is to train all the existing cardiologists to use more intravascular imaging, like IVUS or OCT, to optimize these stents. And perhaps if we can have longer stents which have all these properties, that's best of both worlds. And I think that's something which is presently being looked into, and multiple device companies have come out with their iterations, and I think that's going to be the future. The other aspect of stenting, which is impressive these days, is what we call as precision PCI. A blockage, just by virtue of being 70%, may not limit blood flow.
Right.
The human eye is pretty notorious to estimate blockages. Sometimes we're off by 10, 20%. It is what it is. So to judiciously use physiology, if a blockage is 70%, does it really limit blood flow? That's when you have a concept of pressure wires and things like that. Where you put a pressure wire which can detect pressure beyond the blockage and before the blockage to see if there is a percentage of blood flow which drops across the blockage. And if it does, then you put in a stent because it's limiting flow, and that's the one you need to stent. Now, that tells you whether you need to stent or not, and if you combine that with intravascular imaging to choose the right stent, the right length, the right diameter, you optimize it pretty well. And that's precision PCI, when you combine all of these things together and bring it together. I think that's the future.
So our residencies, med school students, Prasad just put it to the simplest form, but also went detail on you. And I love what he just said. But now we want to know, because med schools, what's going on right now? We love music. What kind of music you listening to right now?
Oh, that's a good question. The music I listen to is
what you getting into?
I usually let my cath lab staff, pick their music, because sometimes you want to keep them happy too. I don't do that always, but I listen to a mixture. I mean, classic rock, a lot of that. U2 and Led Zeppelin, those guys. Blue Oyster Cult was playing this morning. Don't Fear the Reaper. That was going in
Are
there.
you serious right now? That's good
That
stuff.
was good stuff. And then Aerosmith was going in the lab this morning, and the Bee Gees.
The Bee Gees.
Yep, Staying Alive. Never play Another One Bites the Dust in the cath lab. Don't.
Exactly. Don't do that.
But
That's
when you're down and doing, when you're down and you want to have some inspiration, play Eye of the Tiger from, that's some of the stuff we play. These are some of the
80s,
classics.
70s all day.
We got a mixture, and then if you do that for too long, the younger folks in the lab don't like it, so we switch it up to something. Something which you see on TikTok, for example, all the newer stuff. We play a mixture of all of these things, but we need to make sure that, everybody gets to listen something of their choice. So we kind of rotate. Some days I play my stuff, some days I let my lab play whatever they want, and we have a speaker inside, so we make sure that we're not too loud. Sometimes we even let our patients pick our music, so that they feel nice and relaxed, and then we go from there. Those are some of the stuff which we play in the lab, though. Sometimes it helps us keep our calm, and sometimes at the end of the week, you're tired and you're mentally a little stressed out. Kind of helps you calm down. So yeah.
I love it. That's good stuff. I've come from a device background as well. So what I think a lot of patients want to know was, hey, I came in and you're right, I had a heart attack, and then you guys sent me in for a defibrillator. Like, why did that even, what was up? Like, what happened? How does that happen? Why is that reason?
Right. So, as we mentioned before, the heart has different components. One is, the blood supply to the heart, which is arteries, blockages. That's one thing. And then there's the electricity of the heart, because it has to pump. And for a mechanical action to happen, you need, electricity to fire. Right. And that's a double-edged sword, because when you have a heart attack and you lose some muscle in the process, that ends up being scar tissue, just like a bruise on your body. It ends up being scar tissue. Scar tissue is notorious to cause abnormal heart rhythms, and studies have time and again shown that when the ejection fraction of a heart, a fancy word of saying how good your heart can squeeze. In other words, if you put 100 cc's in your heart and it can squeeze out 52 cc's, then we consider it as a normal ejection fraction. Now, when your ejection fraction goes down below 35%, and if you place them on medical therapy and you fixed all the blockages which lead to that particular event, and still your ejection fraction does not improve beyond 35, that's when studies have demonstrated that you have bad rhythms come from the lower chambers of your heart, specifically what we call as ventricular tachycardia or ventricular fibrillation, and those are lethal. They can potentially kill you. So, in patients who had heart failure and who've had an ejection fraction which is persistently 35% or lower, and not improving with medical therapy, that's when you know that you need a backup, especially when you go into these abnormal rhythms, so that the device can keep seeing every single heartbeat, and when it sees an abnormal heart rhythm like ventricular tachycardia or VT or VFib as we call it, then it shocks you out of it and brings you back to life, so that we can go in and see if we can burn the scar in the form of ablations and things like that to prevent this from happening again and again. Sometimes you might have had a heart attack, but certainly you develop blockages over a period of time, and the rest of the muscle starves from not having enough blood, and that leads to ventricular tachycardia or ventricular fibrillation, and perhaps leads to these abnormal heart rhythms, and that's why you need a defibrillator in that situation.
That's perfect. The thing I think that is really cool about what you're saying is, like, a lot of people don't know that, and I think that it needs to be talked about more. Like, I'm on a Facebook page in a group that is all about devices, and they're all got pacemakers, and they're so worried about every day. I think that, as a physician, these patients come in every day, they're stressed, they're worried, they think, my mom or dad died from this, or whoever, and they're just really worried. So I think the information that we can get out, and the more we can, the quality information and the right information, because I think there's so many people go to these blogs, they go to these different networks on social media, and it's just people, it is not educated people, doctors telling them this information. It's a lot of wrong information, misinformation. So it's really important that we get this out and let them know what's really going
Right.
on. Right.
I mean, there's multiple devices available in the market. One can range from a simple pacemaker. For every behind every heartbeat, there is an electrical rhythm which needs to initiate that squeeze.
Right.
And as age goes by, or if you've had heart attacks and things like that, that intrinsic pacemaker which you have inside the heart muscle fails to act. We call that a sick sinus syndrome.
Right.
And when this happens, you want a pacemaker to keep sensing, let the body do its work, but the moment it senses that your body is not firing that impulse which it needs for the squeeze of the heart, then the device will take over and perhaps give you that extra beat, which is a pacemaker. Right. The defibrillator, all defibrillators are also pacemakers, because if they don't see a rhythm initiating, they automatically act like a pacemaker. And at the same time, defibrillators serve a different purpose, which is, as I said earlier, when the squeeze is, or the ejection fraction is below 35%, and if there's bad rhythms coming from the lower chambers, VT or VFib, then it shocks them out of it. And if your rhythm doesn't recover, it paces you to make sure that your muscle squeezes and you come back out. Now there's a combination device, which is what we call as a biventricular pacemaker or a biventricular defibrillator, is for people who have advanced heart failure and you have specialized conduction tissues on either side of the heart, from the right and the left heart. And when the right and the left chambers don't talk to each other, it becomes like an unhappy marriage. So you want to sync these two, so you have an electrical lead in the right ventricle, and also you have an electrical lead in what you call the coronary sinus, which sits behind the left ventricle. And we use these two leads to time the squeeze of the heart in such a way that this dyssynchrony between both these chambers is eliminated, and people have a better ejection fraction, and they have better improvement from symptoms and things like that. I think people first need to realize that when you're passing out, when you have an unexplained passing out, and when you're beyond a certain age and things like that, this needs attention. You need to talk to your cardiologist to see if your electrical system is functioning okay. You could catch this in a simple EKG. Sometimes you need a monitor for 24 hours or 48 hours. You slap it onto your chest and you continue your day-to-day activities. It records it. We call that Holter monitor. Sometimes these events don't happen as frequently, so we do event monitors which go on for 14 days or 30 days and things like that. Sometimes we put a little zip drive-like thing inside your skin, and it keeps monitoring your heart rates. We call that implantable loop recorders, which can even stay inside for years, and we can detect these rhythms. And if you've had a heart attack, it is important that you follow up. Make sure that you get echocardiograms to see what the squeeze or ejection fraction of your heart is. And if you're about 30, if you're less than 35% on a persistent basis, then you get a defibrillator, and you need to be routed to the right guys to do it, and things like that.
So I think what a lot of people understand. So first I want to say this to all the med students and all the residency students that are going through and want to do cardiology. You're not specifically cardiologists. You have to learn the whole system. So what I've learned even from med sales is that the cardiologists, we had to train or talk to them more about devices on the electrophysiology side, just as much as they know about the stents and the basic function of the heart. So because they feed the patients to the actual electrophysiologist or whoever's doing the device implants for you, or the electrophysiology as far as all that goes to those guys. So you have to understand the full spectrum, not just one zone, but the full spectrum of everything. So what he's talking about isn't that it's what he does, it's just that he has to know that so that he can get the right patients and get them to them efficiently so they can survive and get them better quality of life. So that's really, really a big deal, I think.
Absolutely. I think it's just a combination of multiple little specialties inside, subspecialties inside of cardiology. A solid training in general cardiology to know a little bit about all of these things is important for you to specialize in one certain thing. And you have to be a good clinician, detect symptoms, then you need to perform the appropriate workup, and then you need to fix these things yourself or send them to a person who can do it for you.
So what I'm going to get to now is a little bit touchy. I know it is touchy, that's why I want to get into it. So history has shown that CV surgeons have done a lot of things before. cardiologists just stayed in their own world. They didn't go into anything extreme. And now things are evolving, man. I mean, you guys are doing valve technologies, procedures, extremities, like you said, peripheral work, right? So let's talk about the future, and why that evolved and what's going on with that.
So it's a great question. I mean, historically, we've worked with each other so well. Surgeons do the opening up of the heart. A lot of the procedures which we do these days, bypass surgery for diabetics and a low ejection fraction, has been gold standard for decades together, and it remains undisputed. And recently we've realized that not everybody can withstand surgery. I mean, surgery is still the gold standard for certain young people with a good profile, not much of organ system damage and things like that, and anatomical considerations being okay. Surgery is the gold standard for a lot of people. But there's also, as people grow older and they grow sicker and things like that, there are also a certain fraction of people who don't do well with surgery, and open heart surgery and staying in the ICU, lots of complications, renal failure, deep venous thrombi, and a bunch of other things happen too. And there are certain fractions of patients who don't do well, and as responsible professionals, we need to innovate and find out ways where we can fix the problem of valves or blockages and things like that, repairing the valve or even replacing the valves by not putting them through surgery, because that's just not their best option, right? We live in a country where we have a lot of options for everything, and we need to present patients with different options and tell them the success rates of open heart surgery versus a percutaneous procedure. And as time went by, we realized that there's a certain few patients who were not doing well with surgery by virtue of their comorbidity profile, and that's when newer techniques like transcatheter aortic valve replacements came into play, where you don't have an open heart surgery, you don't have to put the patient on a heart-lung machine. You basically go through the groin and put on a new valve and come back out, and you send them home. Because they don't undergo an invasive procedure, their recovery time is much lesser, much less invasive. And then as the technology evolves, the concerns about the durability of the valves go away too. And recently, 10-year durability data for transcatheter valves came out, and they're just as good as surgical valves with much less of an invasive nature. And surgery is for some patients who have an excellent profile. For some people who just don't have that, we need to have alternative options, and that's where you go into the groin and put a new valve. Or for the mitral valve, for example, we do what's called transcatheter mitral valve with mitral clips, where again you go through the femoral vein and you go through the right atrium, and you cross over from the right atrium to the left atrium by doing a procedure called a transeptal puncture. And then on a beating heart, when the mitral valve's flopping around, you see which segments are perhaps flail and floppy, and you go grab it. And it's a fun procedure. It's an interesting procedure which involves imaging. At the same time, technically, you're looking at fluoroscopy, you're looking at transesophageal echo, and at the same time, you're hitting a moving target. And you clip the leaflets and you cinch it and you come back out. The way I see this moving forward is, we're in probably a few years from now, these are not going to be two different specialties. All these procedures which I'm talking about, we do it with our surgical colleagues, and it's fun to learn from them as to what their nuances are, and they find it interesting to learn, certain things from us, which we're experts at, and it's a collaboration. I don't think it's the lines between the specialty are going to become blurry. I think we're going to learn to do things together because both of us have important skills to offer to the procedure. If things go bad, then the surgeons have to open them up and fix it up by open surgery. Whereas wire skills and things like that, the interventional cardiologists are, they're trained to do that for a longer period of time. And both of us offer these skills. I think it's got to be a symbiosis. It's a mutually convenient thing, which is a win-win for patients. Because if there is a valve which needs to be fixed, we all sit down and talk together and say, anatomically, this is a surgical fix versus a percutaneous fix. And then we decide what is your risk for each of these procedures, and we offer the patients their options too, and then we go from there.
On the peripheral side, I don't think you do a lot of that, but I will say this. The concerns I've been hearing about the peripheral side is just that the stents aren't long enough, and they're not like you said, the stability and the strength kind of breaks down. The longer it is, the when there's blockage there,
Right.
it's harder. So let's talk a little bit about that and some of the difficulties that can happen with that.
Right. The peripheries are a little bit of a different beast altogether. Again, the disease segments are like much longer, as you said, and a lot of people have kidney problems, and you have this is a part of the body which moves around a lot too. And stents, if you put them in the wrong place, they can even have fractures and things like that. So I think that's where the challenge comes from, to maintain the patency of these arteries over a long period of time. There's a lot of important work being done over there, drug-coated balloons and, much more robust stents which are flexible, and perhaps wire skills for the interventionalists are getting better, so they're doing much more work in, below the knee and things like that. Exciting space. It's a much more challenging space because limb loss is, again, a very crucial thing. And people who have disease in their extremity arteries tend to have disease in their coronary arteries too. So they come with a bigger comorbidity profile, and it becomes much more challenging.
You're busy all day. You're working your butt off. You're doing everything you can. You're giving everything you can for the big. But we want to know now, there's a big factor that hit this last year. Like, people are scared right now. Like, it's crazy. Like, it's changed the whole world, how we look at the technology, how you guys run your whole health system now, like from med students now, the access they have, all that stuff. Let's talk about COVID. Let's talk about COVID first on the one touch. Let's talk about what it's done to medicine as far as training people, because they can't come in and do the physical patient training they used to.
So it has changed a lot of things as far as education for medical students, or and then they have osteopath students, and then they have nursing students, because of the limitations due to COVID. The number of clinical rotations haven't been as robust because we try to minimize patient contact. The other thing is, a lot of patients have not really come in for their elective care because hospitals have suspended their clinic services to prevent spread and things like that. And also, people are very afraid to come into the hospital because of, and understandably so, that there is a fear of, contracting COVID by virtue of coming into the hospital. And when the volumes go down, the students cannot examine as many patients and things. So that's affected medical education in a very profound way. So that's a problem we're facing currently. And as far as the public is concerned, there's always this fear that, as soon as I come into the hospital, I'm going to get COVID, which is a reasonable fear to have. But at the same time, I think some education needs to go out that we have systems in place to get you into the hospital and get you out of the hospital in a safe and sound manner. Everybody inside the hospital, including the doctors and the nurses and anybody who enters into the hospital, is required to wear a mask, and we're monitored on that. We have people looking out to make sure the rules are being enforced, and we make sure that your time in the hospital is minimized, and when we try to expedite your procedures, make sure there's less number of visitors and things like that. We do same-day stenting procedures and same-day discharges so that you don't need to spend the night in the hospital if you don't have to. We're doing our part to make sure that the spread blunts down. We're doing our part to wear all the protective equipment to make sure that it doesn't spread. We're doing our part to make sure that you get in and out of the hospital in a safe and sound manner, not neglecting your usual heart health. And that's an important thing for people to consider, because we're seeing a lot of heart attacks. People have been sitting on their symptoms for 48, 72 hours, maybe even longer than that, saying, I'm so afraid that I'll get COVID if I go to the hospital or the emergency room that I'm going to neglect this symptom of heart attack. And it comes back as bigger complications. Time is muscle in these instances, and when the artery is blocked for a long period of time, we're seeing a lot more delayed presentations, and delayed presentations mean much more complications and more heart failure and things like that. So our message is, not to neglect your underlying conditions. If you have symptoms and if they're important, please come into the hospital. We can get you in and safely out. and make sure that you spend the minimal amount of time in the hospital. And we're working extra to streamline these processes to make sure that you get the best care possible and spend the shortest time in the hospital possible.
I didn't think about that aspect, because the baby boomers, you guys are hardworking, tough. You've sustained and lived and gone through a lot of complications and been okay. And now, and you're already, if I can say this out loud, I mean, you agree with me, I'm sure you agree, but you already have always held your health care till the last second and come in. But with COVID now, you're saying it's extended even more because of the fear.
Absolutely.
I never even thought about that. That is
well,
crazy.
I think there's some irrational fear to it.
Right.
I mean, you see the media talking about COVID. It's a very, we don't know much about this disease, and I'm not saying discount this. I think we just need to be cautious. We need to exercise the usual precautions, wear a mask, follow your social distancing. At the same time, if you have a heart problem, these are things which are time sensitive. Right. And, we have to take the standard precautions, come in and get our care before it leads up to a complication. Because what we're seeing right now is people who, the number of heart attacks have multiplied, the number of people coming in for elective care has gone down, the number of people who are coming in with heart attacks and having waited on them for a long period of time with complications has dramatically gone up. Wow. And that's just not a good situation to be in, because you're having a COVID surge, and at the same time you're going to have elective problems which are much harder to deal with when they're not dealt with in a timely manner. And that's a huge problem right now. I think we need to respect the fact that COVID's going to be there for a while, and we're trying our best to contain the disease. We're trying to keep our social distancing going and wear a mask and things like that. And we want to do our best to keep you safe in the hospital and get you out of the hospital safe, without you having to wait too much for it.
That's good stuff, man. I really appreciate that. And I think that the community needs to hear that. So we're going to talk about social media a little bit and the importance of it right now, only because this aspect of this right now, I think if it helps one person or one patient, we're good. Like, I think it's really beneficial. Just like you say, if you save one patient, it's a huge deal. Like, so what we want to do is we want to educate one patient, one person at a time, or one mom that is ahead of her, because moms seem to be a majority of the leaders of the home for healthcare. And we want them to feel secure that they can go to Mercy in Springfield, Missouri, and get the best care and get safe care, like you just said, with COVID going on right now, and get the treatment they need. So how important do you believe, like, being active as a physician and being connected to your community is through social media? That's the way everybody's looking at things now. How do you feel about it?
I think it's very important that people receive authentic information.
Yes, sir.
Social media is great. I'm a fan of it because information spreads fast on social media. And if we have a good, valid channel where people can get authentic information, and if it does spread fast, it's a good thing. People are more aware of what to do and what not to do, what to neglect, what not to neglect. And that's a great channel for rapid dissemination of information. But people also need to understand that they need to know their sources and make sure that their sources are reliable, because fear-mongering is unfortunately going on too, because there's some folks who have half the information, and that spreads amongst people, and there's irrational fear there too, and then it leads to people staying at home, neglecting their heart attack symptoms and coming in late. I think personally we need to strike a balance between working hard in the hospital. It's a constant challenge, because time is of the essence. You have your personal life, you have your professional life, which takes up a significant amount of time, and then you have your responsibility to the community, to be in there and educate people as to how difficult the situation is, and you have things like video visits, you have telephone visits with your physician providers, and even if you don't want to come into the hospital, make use of these channels and make sure that if you're having symptoms, try to get them, on the phone or perhaps on video visits. And if you really, really need to come into the hospital, we'll get you in and out safely in the shortest time possible. And I think that's an important avenue for it.
Dr. Prasad, thank you so much for your time. I really appreciate you. Q Contrive, Q World. We love you guys. Thank you for your support. As I said early in the position, please hit the button to subscribe to our channel, YouTube. Also hit the bell so we can get notifications to you and you guys know when we're bringing out new and upcoming podcasts. Hope you guys have a good week. Be safe. Wear a mask, please. Let's reduce this COVID infection, and we'll talk to you guys soon. Take care.